So in this section, we're going to talk about the sequencing strategies for relapsed and refractory metastatic renal cell carcinoma, particularly second, third line and beyond, and how we define patients that have disease progression on the frontline setting. Nick, can you tell us a little bit about your thoughts on, you have a patient on frontline therapy, what are you looking for? How are you deciding that that disease is enough progression to say it's time to switch?
Yeah, so traditionally we've used RECIST, and I think it's a good, reasonable guideline, 20% growth. But a 20% growth in an asymptomatic lung lesion, I don't get too hot and bothered about that. New lesions, those worry me. A painful new lesion, certainly a new liver lesion, new sites of disease anywhere, those are usually signs of progression. And we know that the frontline TKIs give us about a year, maybe a little less. So my feeling is that, you explain that to the patient. You say, on average, these drugs work for about a year. And so when you get to the 8 or 9 months mark, you start sort of setting it up and saying, now look, we might be running into stormy water here. And let's start talking about second line therapy. It's not real hard a conversation to have as long as they are still in remission. But if they walk in one day with a new brain met or a painful hip lesion, then you got to go, okay, now we got to have the discussion. So it varies, and any oncologist worth his or her salt will know how to handle that situation.
You bring up a good point, and I use this, and I'm interested in other people's thoughts, and that is the timing of that progression. So you said, look, I'm thinking that on average these are going to last 12 months. As we get out to 9 months or so, I'm starting to prepare the patient. To me, I think that's a really good benchmark. When I look at the data, and there have been a couple of these kind of retrospective analysis suggesting that patients that progress at 3 months or progress at 6 months have a much worse survival. Yep. And patients that are progressing 9, 12, 15 months out, a much longer survival. Now, you could say, well, that's obvious, right? Well, that's 6 months difference between those, right? But it's a bigger difference in survival than 6 months. It's like a few years difference.
Yeah, it's called conditional survival. And Lauren Harshman had a nice paper in Lancet Oncology about that, and Tony helped get that paper out. It's actually, if they get a response and their quality of life goes up, their tumor burden goes down, their prognosis improves considerably. And then you can tell them, look, you're doing great. You don't need to worry so much about this early relapse. But at the beginning, you do. You have to be afraid.
I think that's a really important thing to me is when I see a patient's first scan on a therapy 3 months into it, and I see growth.
Right.
That's not the kind of case I'm going to look at, even if it's only 20%. That's not the kind of case I'm going to look at and say, well, let's just keep watching that, right? Because that's the patient that's going to get into trouble. Or you see new lesions, and you say, well, they're small, maybe I can just watch them. Doesn't matter. That's a bad sign. Whereas if that's happening at a year, I feel much more comfortable following that patient. Now, what about all this stuff about immune resist criteria? Raj, does the same rules apply when we're dealing with immunotherapy as with TKIs? Because now we're hearing that there can be these mixed responses. There can be a little bit of pseudo-progression. How do you handle that, knowing that that could also be a marker of a really poor prognosis?
So that's a very interesting question, and I think we are all dealing with it on a day-to-day basis. We know that immunotherapy are not expected to induce objective responses as we have seen with the VEGF TKIs. So if I see disease stabilization or slight growth in the lesions, I'm not as worried as I am if I see the same thing with TKI. So I would like to give more time to immunotherapy before giving up on immunotherapy. So that is my practice.
Are there a few caveats? Nick mentioned symptoms. So how do you deal with patients that maybe have a little bit of increase, they get some symptoms, but is that inflammatory symptom? Is that really disease progression? I mean, it gets difficult. You can see how there's a lot of gray area in this space.
Yeah. So again, no, I don't think anybody knows the right answer here.
Well, Nick
obviously, so obviously, if a patient is going downhill, performance status is really getting worse, that is a very strong signal for me to switch therapy. On the other hand, if patient is doing well, feeling better, I see the labs, hemoglobin is stable, and LDH is not going up, and lesions have gone up a bit. I think I feel comfortable keeping those patients on immunotherapy.
They've even changed the criteria. The immune RECIST criteria even looks at the patients who've had progression of disease and then they have a response. They actually sort of don't count your progression as an event. They actually count your response as an event. So they're giving a little bit more leeway, recognizing the pseudoprogression or the infiltration of T cells into the tumors can actually sort of, I describe the patients, it's like you get an atom bomb, you have the little flare, you have the cloud, then it dissipates down. So too with the patients, but even when it comes down to our grading of these patients' responses, the RECIST criteria has adjusted to that.